So we have two topics to discuss, is the team approach, and the second is the role of surgery in neuropathy, and I'd be fascinated to hear Dr. Bolton's take on both.
Thank you very much. I mean, those were excellent talks, and as you pointed out, with my colleagues from the Ukraine, who I was with last week in Poland, as I mentioned at the beginning, the tragedy of not being able to triage because the police were waiting for them at the hospital would have taken them straight to jail, and having to set up a field hospital is a major challenge, and there are many fatalities there who would have been prevented with the excellent service that was available, as you beautifully illustrated in Boston. So that's a big contrast. To turn to the first talk, I thought John Steinberg was actually remarkably good. Not surprisingly, I should say, but it was very fair.
You missed my first slide.
I missed it because I was told by Armstrong that it was starting 20 minutes later, so I was getting the talk ready for tomorrow afternoon.
You're correct, but my first slide disclosures were none, followed by the fact that Andrew Bolton is in the room, so that directly influenced my talk. But no,
I thought it was actually very fair, John, and your conclusion I would concur with. And one has to ask the question, why did anybody in the first place think of decompressing nerves? If you understand diabetic polyneuropathy, and you cited my technical review, which I have to say was like writing a thesis, but you will see there that the mononeuropathies are very distinct and not associated with polyneuropathies, number one. Number two, diabetic polyneuropathy is an active process of degeneration and attempts at regeneration, and this is proximal, usually in the calf or even higher up. Increasingly, there's evidence that there is central nervous system involvement from colleagues from Oxford and Sheffield, who are showing not only involvement of the spinal cord with a decreased volume in patients with peripheral neuropathy, but also even the thalamus. So one has to ask, why would one even conceive of decompressing a nerve in the tarsal, for example, a tarsal area, when this disease is active proximally? And that's been the big bugbear, if you like, with those of us who have been highly critical because of the lack of any randomized controlled trial or any really good evidence for something which is potentially invasive and potentially could even make things worse. So that's my concern, but I thought your summary was extremely fair. So thank you very much. That's my comment.
The other interesting factor is that this surgery has been going on now for 20 years, and the surgeons involved have been asked to do randomized trial. And interestingly, they've never done it, and which is the same with dressings, et cetera. Why do people not do randomized trials? It's because they don't anticipate getting a positive result. So I think that the lack of randomized trials in this is just as telling as your conclusion. Any other questions?
I would just throw out there, I think it backs up what Andrew just said at the microphone, though, that understanding the process for which you're considering to do surgery makes the most sense. And in our pattern, we have an amazing set of plastic surgery nerve surgeons who are trained at Georgetown to do this, and it's up to us to be the rate-limiting factor for what patients am I going to send them. And I send them my painful diabetic neuropathy patients who clearly have entrapment, and they have tremendous results. But I don't send patients that I expect them to somehow restore their numbness, because that's just not surgically possible, in our opinion. It's not making for a good debate when we agree.
Yeah.
Yeah.
So, John, how many patients do you think you refer a year for nerve release surgery?
For painful, if I'm seeing 30 patients in a clinic session, I'm probably sending 1 or 2 per session. I'm pretty aggressive with that because I'm not a big fan of the medication management for diabetic peripheral neuropathy beyond I may make a brief attempt at Lyrica, but I generally send them quite quickly for nerve release if it's painful neuropathy.
And your feelings with, obviously, you've used, there. So, any other experiences? Someone must work in a nerve, David, I'm sure you have something to add to the discussion.
Superb talks, by the way. Even you, John. But
Thank you.
But
should I show the video again of the
yeah,
TAL? I can show the video again.
Just really a masterwork.
Thank you.
Your best work. But two patients a session? I mean, that's are you sure?
I have a lot of.
I mean, that's a lot of.
Your patients with diabetes don't complain about pain.
Well, what I'm saying is, I mean, that seems like it's a nice sample. I mean, even if you took the square root of that, that's a lot of patients, which is what I'm doing, and that could be enough to enroll in a pretty robust study over a period of time. And by the way, just to counter your, I mean, I think your skepticism is warranted, but I must say that some of the people involved with this and that tend to be evangelists for this surgery actually have a fairly robust plan for an RCT underway. So I suppose we'll all have to stay tuned and we'll see what happens. But
I'll give them the benefit of the doubt 20 years later.
I think let's do that. Maybe there'll be an overnight success in 30 years. But there you are. But that's a lot of patients. To it, really.
I don't like pain. I have to.
What,
Sir.
James McKee, Podiatry. For Dr. Eriksson, in the wake of what happened with the bombing in Boston, what changes have been made over the past year, and what kind of did you change as far as preparing for this next marathon and really for the next large-scale mass trauma that occurs?
Good question. If we start with the medical or surgical side, we were very comforted to see that our system works for, let's call this a medium-sized disaster. Of course, we don't know if we had a much larger disaster, if our system would work, but we were actually surprised by how well our system at every level worked. Clearly, the police work and the like on site was very helpful because they helped bring a number of patients to the ambulances and to some to the hospitals. What really didn't work was that the FBI didn't respond to the warnings that they had gotten quite early on regarding one of these people. This year, as far as I understand, the marathon is going to go on exactly like it did last year with much increased security, and there will be some increased level of preparedness at the hospitals, but the increased security along the race course is, I think, really the only change that we are going to see, at least that we, the public, are aware of. There may be a bunch of things happening behind the scenes.
Dr. Eriksson, for the audience which may not be aware that plastic surgeons actually do other things than facelifts, Botox injections, and breast implants, can you just clarify what a breast surgeon might do? No, what a plastic surgeon actually does in terms of taking care of these mutilated limbs and or possibly help for diabetic foot wounds ravaged by infection?
We pretty much manage all the soft tissues outside of the vascular systems. Of course, the orthopedic surgeons take care of the bones outside of the hand or the forearm where we do it jointly. And then the vascular surgeons take care of the arteries and veins as needed. But everything else, if obviously we do a lot of soft tissue debridement, we do a lot of nerve grafting. We sometimes do muscle transfers in cases of need, usually as a delayed procedure. We provide soft tissue coverage over the bones. Often skin is not sufficient, so we either use muscle in combination with a skin graft or composite tissue of a muscle and skin flap to not only provide the best cover, but also, particularly in some of these patients, many are young and quite cosmetically concerned, trying to restore not only function, but also the normal anatomic contour of the extremity.
I'd like, since Dr. Edmonds is not here, I'd like both faculty members just to comment on dressings, how to simplify them, how they use them, so that we can have both the view of from a podiatric perspective and a plastic surgery perspective. John, do you want to?
Yeah, I can give you our perspective from Georgetown was that while we certainly advocate for the technology and the science and the new discovery when it comes to topical wound care and dressings, we of recent have become much more critical, and we found ourselves sliding down a slope of engaging a lot of dressings that there really was minimal evidence to support the cost and the utility and the function of these dressings. So we have gone from a closet in the clinic that was a wide array of what could be seen in some of the biggest of exhibit halls to a clinic that now really we have usually a member from each category. We have a basic foam dressing. We have a basic enzymatic debriding topical that we'll put on. We have a topical antimicrobial, a couple of selections, but we have really moved away from a lot of the advanced technology unless they can convince us with their data, which so far has been rather underwhelming as far as a in vivo data critique.
I agree with all of that, and we could see it from another angle and ask ourselves, can dressings help reduce the pain? Yes, many of the moist dressings do help to reduce the pain, but we could certainly use better dressings of whatever kind that will help us reduce pain. Many of the dressings that provide antimicrobials, not only do they decrease the bacterial counts, they also have a deodorizing effect, which I think we should not ignore, because some of the wounds are quite personally and socially embarrassing because of the way they are. Of course, sometimes we like to add debriding agents to the dressing, and because of the fact that we treat a lot of large wounds, we frequently use negative pressure in our dressings, but generally we don't do anything particularly special. We follow the same rules that John just described.
I think one important thing, when I was talking to you earlier, though, Chris, is the standardization across the inpatient, outpatient, because there's nothing worse than as a surgeon doing a bypass or some type of procedure such as a pedal, and then they go someplace and someone wraps a Curlex around it at too tight a pressure. And I think one of the standardization, and I think we have to be mindful of the VNAs who are getting killed in the economics right now. And what we found is still surgeons or physicians ordering wet to dries to go into the home 3 times a day. That's just not feasible any longer. I was wondering about the comments of all of you on how you feel about trying to go from, when we grew up, yeah, we wanted wet to moist and all of this several times a day, but the longer you leave them, the less VNAs, home care, or other people have to look at these wounds.
You hit one of my pet peeves right off the bat by mentioning Curlex. It used to be the routine inclusion in our surgical packs that there was a bunch of 4x4s, a big Curlix roll, and an ACE wrap for our dressings. And just recently, we finally got fed up with how many were being put on too tight, and Curlix can be hugely dangerous, particularly at the anterior ankle impingement and at the posterior heel. And if that's put on too tightly, you get a gauze burn from that or a pressure injury, and you have 2 new ulcers to worry about. So we've removed Curlix from our dressing kit, and it's all Webril now, all cotton-based roll, which is almost impossible to put on too tight because if you start pulling it, it'll break. So it's been a good learning curve for us to move the residents away from that potential injury, and I prefer the Webril dressing now. But the other point that you mentioned as far as just standardization and looking at frequency of dressings, I think that sometimes we've also swung a little bit on that, Gary, in that I think sometimes we were a little too obsessive about how often we need to be looking at these wounds and how often we dress them. And the more we break that down in a non-sterile environment, the more it has a chance to get exposed, particularly in the home environment and the skilled care nursing environment. The dressing changes there aren't oftentimes the quality of cleanliness that we would like. So we've moved to, that is an area where some of these advanced technology dressings will allow you to do a much less frequent dressing. And in those areas, I think that probably makes a whole lot of sense to engage some of the technology that's out there that you can leave on for 2, 3, 4 days, or particularly underneath a total contact cast as well. So,
I completely agree. Maybe we should have a session where we talked about a wish list. What do we need? There are many smart people, innovators, corporate people, people who can really change things. Maybe we should spend more time on what are number 1, 2, 3 wishes. For instance, I would like very much to see a dressing that would be highly effective to reduce pain. I completely agree with John that if we could have a good dressing that for most wounds would reduce interventions to once every 3 days for our outpatients, that would be fantastic.
David?
Well, this is wonderful. Professor Eriksson, you have, not to butter you up, but there's plenty to butter you up about. I mean, you've just, you've done it all. But, recently you've been doing a lot, your unit's become pretty famous for your composite tissue work, like for instance, faces and such. What do you think the way forward is, Elof, for, where do you see the future for composite tissue transplant? Is there a future? Is this just kind of a flash in the pan? But it does seem to capture the imagination, doesn't it? And I think for the people on whom it works, it can be life-changing.
I like your question, and composite tissue transplantation gets people excited, particularly the face. And when it comes to the face, of the 7 face transplants, our team has done 5 of the ones done in this country, and the first one was in 2009, and all 5 are doing well. And they are recovering a lot of sensation and also have major return of motor function, a surprising amount, and probably because in the face the muscles are weak and the nerves are short, so they're easy to regenerate. The other reflection is that our face transplants are running on low kidney immune suppression protocols, or something similar to low kidney doses, which was a big surprise. We had expected that the skin of the face would be a lot more immunogenic. We have also done hands, arms, and they do well, but not as well. I think mainly because in the upper extremity, the muscles are strong and the nerves are long, so that it takes a lot more to recover function in a hand than it does in the face. We do have an approved protocol for the lower extremity. We have not yet done a lower extremity transplant, but we are excited about it. We are going to do it. We'll probably need to do at least close to a dozen before we start realizing what the utility is. But I think it's an exciting work in progress.
Yeah, maybe to put a coda on that, especially with everything you were talking about, the Boston, the bombing tragedy. I don't know if everyone saw in the audience, you were all here at DEFCON, but just before DEFCON, the TED conference, which is a superb conference, was on, and one of the most popular ones was featured a young lady who was not a prima ballerina, but a professional dancer who had her leg blown off above the knee in the Boston bombing. And Hugh Herr, who's a friend of ours, who runs a Boston company called iWalk, it was instrumental in making the prostheses. I mean, they're amazing prostheses. Very expensive, but amazing. And she had her first dance on stage at the TED, and that was just spectacular. And to see that, maybe that's the future of, maybe composite tissue isn't the future in the lower or upper extremities because of the reasons you said, but maybe it is in these very well vascularized places, just like you mentioned. But I think it's captures the imagination for sure.
I agree with that, and clearly this is work in progress. And also, I think we learn from each other. It's not limited to one area. This is really a very similar problem that we are trying to help solve from different angles.
Well, when you put the first foot on, I think we got your toenails for you.
On that note, we're going to break. Thank you all for your... I'm sorry, one question.
Yeah, I'm not even sure if you have the answer. I'm actually an infectious disease fellow. My name is Anuj, and this is really more of a question to follow up on your Boston bombing presentation. You know, what I was fascinated by was, is there a plan that is already in place that coordinates the police, the EMS system, and the hospital administration to set something like this up on an annual basis? Perhaps the jurisdiction of the city helps coordinate that effort. Was there something like that in place when this accident happened, or was it developed sort of ad hoc, you know, like on the spot?
If I understand your question right, I could rephrase it and ask, is there a high-level disaster plan for a city like Boston? Yes, a very highly integrated disaster plan that goes into pretty good detail for each hospital for a medium-sized disaster. My own personal concern would be a nuclear disaster. We are completely unprepared for something where the victims would be in the thousands, and I don't even want to think about it. We probably should spend some time thinking about that, because there are fairly straightforward measures that could be undertaken to limit the total impact, but nothing is done in that area.
Thank you.
Thank you all.